go green, and then you're...
Good morning, everyone. We're going to start now, so please turn your pagers and cell phone to silent mode. We have two presenters today. We have Tamara Parsons, and she's a Vice President for Quality and Patient Safety at Johnston Memorial Library for Mountain State. And then we also have another presenter, Dr. Hughes Melton. He's a CMO at Johnston Memorial Hospital, and he also is involved in graduate medical education at Mountain States. And the topic today is using the EHR record EHR to improve quality. Thank you.
Well, thank you very much for your time this morning. I'm going to get started with some introductory and background slides, and then Dr. Melton is going to be providing some very specific examples. First wanted to share with you that we have a couple disclosure statements to post for you. And then the next slide is really just our introduction yet again. Wanted to first share with you the objectives that we outlined once we were aware of the topic, because we wanted to make sure that we covered the objectives up front so that you can know, one, what we anticipated covering, and number two, hopefully would not walk away dissatisfied with the material that we covered. So a couple things that we'll touch on today, they'll serve basically as our agenda for the next roughly 25 or 30 minutes, is just touch on the state, if you will, of EHRs, or electronic health records, some basic requirements for improving quality, and certainly we could talk for days on methodology to improve quality and what really is required, but we just wanted to touch on that as a frame of reference. Also, some examples of ways that we can match EHRs and the information that they provide to us to those requirements for improving quality. Dr. Melton is going to go through several examples from other healthcare organizations and medical staffs on how they have effectively been able to use an EHR to facilitate quality and improvement. And then he'll share with you an opportunity and a challenge, if you will, to use the EHR in your environments. And then we have outlined a couple of different sources for you if you want some more information. So going forward, before we actually jump into anything, we thought it was very important to at least reference some key terms, and there's just 3 of them that we're going to be using, because while we all know what an electronic health record is, you can actually have a variety of interpretations around that. So we wanted to share this definition of an electronic health record. We actually just pulled that off of the Medicare webpage. So an EHR is an electronic version of the patient's medical history maintained by the provider over time. And this is where it's important, because there are times when, I know we do this anyway, we tend to slip into referencing or looking at the EHR as just an electronic record of the patient's chart, when actually it's so much more, and that's really the point of our slides today. So it's not only just all the details relative to the patient, but it actually provides access to that information and is very, very effective when it's appropriately used to streamline the clinician's workflow. The other term that we wanted to make sure we touched on was the term quality. Is actually kind of a difficult word to define if you're ever asked to actually intentionally define the word quality. A very basic definition of quality just came out of the Oxford Dictionary, and that's degree of excellence. We also looked at the Institute of Medicine, and this one in particular we felt like was very, very important for this particular morning, That's the extent to which health services provided to individuals and patient population improve desired health outcomes. And that's what we're really after when we're talking about quality in health. Additionally, the Institute of Medicine definition said the care should be based on the strongest clinical evidence and provided in a technically and culturally competent manner with good communication and shared decision making. And there's a lot of key words in that second sentence that you're going to see throughout the rest of the slides this morning, particularly clinical evidence, because we're going to touch on the EHR and its impact on our ability to provide evidence-based care. We're certainly technically competent. There's a certain amount of technology and competence in that technology that's necessary to fully capitalize on EHRs. The culture around the acceptance, if you will, of an EHR and the tools associated with the EHR. We're going to reference that in an AMA article. And also one of the values that the example organizations have pointed out, and we'll share with you here, is the value and the importance of communication and having the right information to make good clinical decisions. So those are all the things that we're going to touch on, and so the definition felt like was very important to share with you. And the final term is just the term improvement. Again, improvement can be defined as the process of getting better, so that might be a very basic definition. There's actually a definition, if you will, of improvement we found in the New England Journal of Medicine, just actually on their webpage. And that is that improvement is measuring the quality of health care. So they started out with the word measuring as opposed to that basic getting better. So I think it was important. They focused on measurement. And using those measurements to promote improvements in the delivery of care, to influence payment for services, and to increase transparency. So a little bit different and a much more broader definition of improvement, if you will. So as we kind of looked at that information just very, very briefly, we thought, well, that's all well and good and certainly helps us frame the material that we want to share, but what's really critically important is for each person to really think about in a very personal way, how would your patients define quality and what might that be to them? And certainly it would mean the process of getting better, I imagine, and it certainly would incorporate some type of degree of excellence. At the same time, quality probably varies individual to individual, so it's important to know enough about that patient to know how they might define quality and how would our patients define improvement. And is that realistic? And is there a way for us to communicate in such a way that we can build upon what their understanding now is on improvement and how we can get them to that to that next level? Excuse me. So just a couple terms that we wanted to talk about from a foundational standpoint. So the next slide addresses one of those agenda topics on our objectives, and that is the state of EHRs. And as I cover this, wanted to share with you that adoption and the use of EHRs is accelerating these days. EHRs have been around actually for more years than I realized. Some of the things that have facilitated the acceleration in the use and the acceptance of EHRs is we can't really diminish the value of government incentives. There was and I'm going to read this, so I recognize it as the HITECH Act, but it's actually the Health Information Technology for Economic and Clinical Health Act is actually the full name of the HITECH Act. Provides some pretty lucrative incentives for organizations and practices to implement EHR. So that has certainly helped facilitate the adoption and the deployment of EHRs. At the same time, that implementation varies across healthcare organizations and it varies across vendors. There's 4 key components of an EHR, and again, basic information, but I think it's important so that when Dr. Melton starts to share with you some of the examples of how these organizations and medical staffs have implemented EHRs to improve quality, it's important to know those specific components. So those 4 key components of an EHR include the clinical data repository, which is commonly understood to be part of the EHR, the electronic health record, which if there's anything we remember in the 4 components, it's typically that electronic health record. But it also includes the clinical decision support system embedded within and throughout the EHR, as well as computerized physician order entry. So when we reference EHR and when these organizations in their examples reference EHR, they're referencing any or all of those 4 different components. would you like to step in now?
Great. Did you give them any background on why I'm late?
I did
okay,
not.
that's fine.
I did not.
So, my name's Hughes Melton. I'm the Chief Medical Officer for Mountain States Health Alliance for the Northeast market. I apologize for being late and saying maybe you guys are playing. Okay, yep, I need the mic. Thanks. Good. In your clinic, do you guys use an EHR? I'm not very familiar with, okay, what is it? Allscripts, all right, got it. Is that the only one that you guys are using in the outpatient environment? Okay, great, all right, so it's not just one. Good, excellent, okay. So you'll get exposed through your rotations to more than one EHR, I would imagine. Four different EHRs, joy, yeah, yeah, 2 would be enough. And on the inpatient side, of course, you guys are using Sorian in Mountain States, which, of course, there's not an EHR yet as part of that. We do have physician order entry. So when we talk about the different components, that is a really important component. And often people will talk about EHRs as kind of different levels of EHR. So first is kind of that data repository. And really even in the old days when it was pretty much a billing system, there was still some pretty good information you could get out of that because they would enter the CPT codes and you can look and see, well, when was the last time I ordered the CPT code for the A1C for my diabetic. And so you could get some information out of that EHR like that. But then they, of course, added on different capabilities. The most valuable of which, Tamara and I would argue, is the decision support tool. And often, how that presents itself, it can be, do you get any alerts in Allscripts, like health maintenance items that are due and some kinds of things? Yeah, exactly. So that's kind of what's behind that. And what's important for you to understand is that there are folks sitting up in IT, right? And they're creating these queries as a general rule, and the query basically takes that information on that patient you're about to see and it runs it through these different rules, right? So patient older than 50, last time a colonoscopy was done more than 10 years ago, bing, you get a flag, they need another colonoscopy. And so the challenge is that, they're IT guys. And so when you're interacting with that software, if you start to see, well, hey, I'd like a reminder on this, or this reminder isn't working for whatever it's wrong, or that sort of thing, you're the ones using it. And I'll tell you, often you know how to use the software better than your attendings. No offense to the attendings. But the fact is that when I work with young med students up in the Northeast market, they pick up the record like that. And they figure out shortcuts and stuff that, the attendings are like, how'd you get there that fast? And so you have a lot to offer when you're learning how to use that system. And I don't know exactly what the mechanism would be for feedback, probably up through your chief resident and then up through your faculty. But just to emphasize that you're key users. Let's see. And then varied levels of penetration. What that means is that you can have the same EHR, right? Allscripts is in the infectious disease clinic, and it's in the pulmonary clinic, but they may not be using all the features in the ID clinic that they are in the pulmonology clinic. And so that's that penetration that we're talking about. And when you go from place to place, and that can be from one system to another, right? Holston Medical Group, they use Allscripts, right? And from talking to them, you can make an argument that they're certainly using features of it that we're not using. As far as I'm aware, it's not an area that I spend a lot of time in. And so just recognizing especially you are going from, clinic to clinic and department to department, you're going to bump into that. So don't let that frustrate you. And it may be they're not using it because they just don't know that it's there. There are multiple ways to get to the same place in an EHR a lot of times. And so, and sometimes folks don't know how to get to a particular feature, that sort of thing. And again, you can be a resource to the faculty team, especially the senior residents. When you're working with an intern, make sure to show them those shortcuts that you learned. It's going to save them time, and if it saves them time, it's probably going to save you time too. All right, where's our clicker? Right here. Anything else to add to that slide? No? Okay. And if you have any questions anywhere on the line, please raise your hands as we go through. All right. So 4 major things that we need to have in place to improve quality, and none of these are going to surprise you. We just want to share some practical examples of where we've seen them in action. And what's the role of the EHR specifically in those 4 items. So some of the specific examples that we have in the Carillion system in a later slide, and we'll just jump to that because I think that's our next one. Yeah. So Carillion found that just when they used Epic, right? Just by implementing Epic, and the fact that that chart was available across the entire system and was legible, which is always nice. They attributed, and evidently I don't think that they did a lot of other interventions to try and bring down their length of stay. There's all kinds of things you can do to try and bring down length of stay that I'm sure you're familiar with. But they felt like they could attribute this drop in length of stay from their EHR implementation. And so it just speaks to, you're in the pulmonology clinic, seeing somebody who went home 2 days ago. Here, you may or may not have the discharge summary. You may have to go into Sorin and find it, or in the EHR and find it. There, it's right there, because Epic is used, my understanding, with the inpatient and the outpatient environment. Now, I'll warn you, electronic documentation is coming to Sorin. And it'll probably be everywhere within the next 12 months. I don't have a whole lot of details on that. It shouldn't really be a surprise. I mean, I think everybody knows that's where we need to get to. It's just a matter of working with Siemens. Now it's Cerner, right? Cerner bought Siemens. To get from us what is it that we want, because they'll customize those documentation modules. So that's going to take some time, and in fact, they had a meeting last night, I think, or tonight, maybe with the PAG. Yeah, I think it's this week with the PAG, which is a group of physicians, kind of a cross-section of physicians, to sit down and say, hey, this is what the module looks like, suggestions, that sort of thing, and then they're going to build that, and then it will be rolled out stepwise. Who was here for the rollout of our physician order entry? Maybe some of the third years, or some of the faculty for sure. Yeah, exactly. So we kind of go facility to facility to facility. We hope to learn from the first 1 or 2, so it's not quite as rocky in the later ones. So the argument with that last slide is, yeah, I mean, sometimes it seems like you can't chart as fast when you're charting in an electronic record, but there are many other benefits. One is length of stay. I think everybody recognizes that if you hold your readmission rate constant, decreased length of stay means better care for the patient. We don't want our patients in the hospital. It's a dangerous place to be. Remind me what it was that the veterans... Steal your mic.
The Veterans Affairs Hospital in Central Iowa developed their own product. So they actually incorporated and integrated a home monitoring system. That's the home monitoring system into their EHR. So they were making decisions about their patient, and they had at their fingertips the information for the 3 weeks prior to this visit or whatever brought them into the system. And so that's the main thing. But interestingly, they weren't on Epic or Eclipsys or McKesson. It was actually a homegrown product.
Yeah. Does anybody here use the VA product? Because, of course, we have a VA system here. I trained at UVA, and we went down to Salem and their system. They're pretty far ahead of their time, actually, in terms of adopting electronic documentation and whatnot. For Mountain States, an example here might be Glucomander. You guys are familiar with Glucomander? Yeah, kind of a love-hate relationship. But I mean, when you look at the data, it works. It's just a matter of making sure that the providers and the nurses understand the tool and understand how to use it. But I mean, when you look at what happens to folks' blood sugars when you put them on that, especially in the ICU, it's amazing. All right. So use of evidence-based practice. So Tara, the example here, is this used to be the process that when you wrote an order, the process for it finally being executed. Right? Did I have that right, Tamara? And so, hand writes, oh man, here you go. Got to find the order, got to double check it, blah, 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 blah. And so when they implemented physician order entry, which, I mean, I was around for that and around for that where I last worked, docs are used to just and you're done, right? And so, yeah, maybe it takes a little bit longer to put those in the system, although I'd argue once you get used to it and you build your favorites and all that sort of business, it goes pretty fast. But I mean, it saves all kinds of work. And what goes up, well, if that last slide, if these are handoffs and communication points and whatnot, what does that set you up for? Failure, exactly. Errors, exactly. So mistranscription, I mean, you name it. So it's like the old game where you get everybody in a circle and each person, you start whisper something, and by the time it gets around to the other, it's completely different. So, that's safety issues, better quality care that you get from, in particular, physician order. And let me see if there are any other examples here. Ohio Health. Tag team.
Ohio Health and Doctors Hospital, which is one of their larger hospitals in Ohio Health. This is really more about their development and deployment of order sets. They got a group of subject matter experts together at Doctors Hospital, created the draft order set, fed it over to the medical staffs at all the other hospitals for input, because their goal was a single order set, but they wanted to do that, balancing the input across a broad group of providers.
Awesome, and there's a balance there. How many chest pain order sets do you find when you go into Sorian right now in Mountain States? One? You guys, do you use order sets? Tell me you use order sets. At least one, yeah, exactly, that's right. Yeah, I think, let me put this back on. Last time I looked, which was a week or two ago when I did a night shift, there were about 4. Depends on where you look and whatnot. But the challenge is, it's not realistic to just build the order set and say, here you go, deal with it, use it. We don't care what you think. And so order sets usually bubble up. We want them to bubble up from the end user, right? And so that you have buy-in to using the order set. Plus, I mean, chest pain, the dynamics around chest pain care at Johnson City Medical Center, they're different than over at Johnson County, right? Or up in Norton. Or some other place. And so, one size does not fit all. That said, you don't want one order set for all 14 different hospitals in the system. And so, what they found is at Ohio Health, what Tamara was saying is, they started with a couple, and I think my understanding is they gradually, narrowed it down to, I think they were able to narrow it down to 1. And you can have flexibility within an order set by different, drop down. Y'all are familiar with how the order sets work, but in Mountain States, we just talked a little bit about that. Often you will have a couple different versions of an order set. And there are other order sets out there you may not see because they don't necessarily turn them all on for every single facility. So that might be why you're not seeing the 3 or 4 that I often see when I get in there because I work at different facilities. The other thing about our order sets is when you're in our order set, so, all right, time of truth, how many of you have used an order set somewhere along the line in the Sorian system by a raise of hands? Okay, good. All right, good. All right. So in those order sets, have you ever seen the blue words in blue within that order set? Maybe, maybe not. Okay, so now you know to look for them. And what those blue words are is they're a hyperlink. And they're a hyperlink to Zincs. What Zincs is a well-recognized repository for evidence-based guidelines. So it's gonna, you click on, and you'll find it next to the antibiotics for pneumonia, and the aspirin next to chest pain, and the ACE inhibitors next to CHF, right? But if you see it next to something that you're thinking you're not gonna order, you might wanna click on that blue and see what the evidence-based guidelines are around it. And it's pretty quick, and it will help guide you through the process of making sure that you're hitting all the check boxes that you need to hit for that patient. And I'll just put a plug in. If you're not using order sets when you're doing an admission, and even if it's a standard admission, we have order sets for diagnoses, right? So the common things, chest pain, pneumonia, CHF, COPD, blah, 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 all that. We've got specific order sets for those disease states. But if your disease state doesn't fit into that, there is a generic order set, and you need to use it. One, it's faster, I think, than picking individual orders. And then also, it'll help make sure you don't miss that DVT prophylaxis at 3 in the morning when you've been up since 5 in the morning the day before. And so when you scan that order set and you go do, 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 it'll help to trigger you to order something you might forget. And you won't wake up in the morning after 2 hours of sleep at 7 and go, I forgot this. Well, when you forget that, it means not as good care for the patient that you took care of that. And nobody wants that. So order sets are there to help you. Any other comments on that? With that. All right, so that's where you kind of got into the open discussion about order sets. Any questions about order sets? I mean, it's a big component of when you're working in the hospital and you're taking care of patients. Frustrations, suggestions? Need coffee? All right, okay, I need coffee. Yeah, sorry. Great question. So the question is could it possibly be that by using order sets you increase the cost of care? Because as you're going through that order set, you hadn't thought of that test, but that looks good, I'll order that. No, that looks good, I'll order that. Yeah, I mean, that's a valid question. And, I don't know of any, do you know of any studies on that, Tamara?
No, there was something in one of these, and I believe it was the actual cost of the investment in EHR, so I was hoping there was something there. Although I have been part of a discussion within Mountain States anyway, the convenience point, there's a belief that contributed to an increase in the CMS reported Medicare spending per beneficiary, which basically is 3 days prior to admission up to 30 days post discharge and all the Medicare expenses associated with it. There's been a steady increase in the ordering, particularly of imaging. So just a couple conversations, we don't really have the facts together yet, but strong suspicion that that's where we're going to find some of the spending that we can cut out. Because the Medicare spending per beneficiary in this area is higher than the median in the nation. So.
Thanks, good. And the other thought I would have would be, it used to be in those order sets you'd have, BNP daily times 7 days. And that's all gone because that's exactly what they found. Is it's so much easier, especially at 3 in the morning when you're exhausted, and you're going to be exhausted the next day and the next day, that you just you order it knowing, probably going to be a 5-day hospital stay, and they're going to need it every day, bonk, and it's ordered. And there was a lot of unnecessary cost, but also, morbidity, because you can track the hemoglobin of a patient over time if they're getting a lot of blood drawn, down it goes. So, but as a general rule, they try to only include in those order sets pertinent labs, but certainly there are lots that you don't order necessarily. So, great question. Other questions about order sets or, yes? Great question. So the question is why not just make all the order sets available to everybody, basically? And it's a balance. That the challenge is that when you go looking, who here has had a problem finding the order set that you want? Right, yeah, exactly. So that's the challenge is, when you're trying to find the one that you want, if there are 500 order sets, 500 or 600, I think, and there are lots of them in the system, that if it's one that you just know you're not going to use, like in particular at the outlying hospitals, that, for example, don't do dialysis. Well, there's no point in having the dialysis one turned on there, but yeah. Exactly, yeah, if they're not doing CAT. So that, and in our current state where we may have 4 or 5 different chest pains, just because we're still trying to consolidate them, I think they try to decrease the clutter on that screen by not making all of them available necessarily. Any other comments on that you can think of? Good question. Yeah, it's a balance, as in most things in life. It's a balance. How much do you put on that order set versus it becomes 5 pages long, and then nobody wants to use it. Other questions on orders? Okay. So prevention of errors is, again, a key component of quality improvement. And I'm going to have you speak to this if you don't mind, Tamara. Yeah.
It really just boils down to their implementation and integration of a thorough integration of their pharmacy system with their EHR, particularly the ordering component of the EHR and then the patient information. Because at Gunderson Lutheran, they started out with that full integration, and because of that, they prevented, which shouldn't be shocking, but I think the article actually focused on how thorough the integration was from the outset. They didn't build and start adding and integrating things as they went. They started out that way so that they had obviously prevention of drug interactions and allergies. And it's a very, very basic comparison against the physician order and the standards. So the standards would be drawn off of evidence-based care before it ever gets to the pharmacy. And then I think the next slide actually shows some of their results. Yeah.
And so, of course, here when you're using Sorian, how many of you put all those orders in, and then you look on the right side of the page and some of them are red, I didn't realize I had an allergy to penicillin would be the obvious one, but also there'll be other interactions on there, and they're there to protect you and try and help you catch things that you might not otherwise catch. So here's the example they were talking about. So decrease medication errors, improve quality. Pretty self-explanatory. So who here is familiar with kind of the system emphasis on sepsis? Has that gotten out to the, I'm sure it probably has. Yeah, okay, good. And so I spend a lot of my time, most of my clinical time is at Johnston Memorial Hospital. And we got a group together 9 months ago, I think, probably. So we don't have house staff there. So 2 physicians, 1 ER, 1 hospitalist, and kind of the quality team, right? So head of quality, nursing, respiratory therapy, did all the different disciplines. And they basically looked at our current state. The sepsis mortality at JMH was not good. And it clearly needed to improve. We actually took a screening tool that was developed at JCMC, a nursing screening tool basically that had been built in Sorian, got it so it would work in MedHost in our ER. So now the nurse is getting flagged that the patient is meeting the criteria for potential sepsis. And we got the order set that was actually, I think, built pretty much here, I think, but got it live at JMH and instituted that and had a pretty amazing impact on sepsis at JMH. So there are different ways to measure that, right? The simplest way I think of it is the 3 Ds, and that's days, dollars, and deaths. So in a 6-month period, how many deaths do you think that we decreased, prevented by our improved quality? Anybody want to take a shot? Okay, so it was almost a 50% improvement, and we do it in terms of actual lives saved. So 26. So in 6 months, we saved 26 lives by better sepsis care. How about days? What days means days in the hospital. So patients were not dying. They're actually getting better quicker and going home sooner. So who wants to take a shot at number of days that we saved? I don't know what the percentage is. I know the raw number. 175. Yep. 175 hospital days saved. And that means all kinds of things, right? It means patients home sooner and not getting exposed to the iatrogenic risks in the hospital. It means they're happier, which is important because we're going to be getting more and more reimbursed on that. It's going to have an impact. It also means, more empty beds, more bed capability, which not an issue in all facilities at JMH. It's a huge problem. Hence, this morning, 17 patients in the ER because there are no beds on the floor. And so if you can get that throughput better, that's better for the entire system as well as the patient. And those resources that are freed up can be used for all kinds of other things. So that's the final D, dollars. Anybody want this is in a 6-month period. How many dollars do you think that we saved? Shot. 5 million? Oh, not that much. That would be nice, though. $1.2 billion, yeah, in a 6-month period. So, and I think the most important thing to recognize and remember about that is 2 docs, 2 physicians involved in that process. Now, there was a whole team around that and whatnot, and of course, it was changing a behavior of the whole hospitalist team and the ED team and everything. But do any of y'all sit on quality improvement, utilization management? Yeah, okay, good. I know that more and more ACGME is moving more towards, that they want you involved in those processes in the health system because when you graduate, meaning, I have most of my life is in the administrative world, just part of my life is still in the clinical world. We've got to have physicians who understand those kinds of dynamics and are willing to work with us to try and make better utilization of our resources that we have available and improve quality and that sort of thing. So, you can make a difference by being involved and giving your feedback. You'd be surprised that, I'm trying to remember the quote. How are we doing on time? You don't have to get very far away from the front line to have no clue what's going on there. And so you're on the front line, and that's why, even within your department, I would imagine that your, the chairman and some of the other faculty who don't spend a lot of time on the front line necessarily, they have other responsibilities that they need to do, they may not realize some of the things that you're seeing. So you need to share your experiences and the problems and the issues that you're running into, both within the department and hopefully on the committees and whatnot that you sit on. You want?
And really, this slide is just to acknowledge the fact that when it comes to improvement, there's a lot of methodologies out there, and it's important to have a methodology when you're approaching improvement, because otherwise it's a decision or a choice, and there's a lot of those involved in making improvements as well. But if you actually see an opportunity to improve and need to do something to change a process, such as what the Johnson Memorial Group did with early identification and aggressive treatment of sepsis, it's important to have a methodology, and some of those include PDCA, or Plan, Do, Check Act, Plan, Do, Study Act, DMAIC, which is the kind of associated with the Six Sigma, Design, Measure, Analyze, Improve, and Control. They're lean, certainly over the last 10 years has gravitated towards healthcare, and there's other methodologies to improve. There's not one that's better than another when it comes to partnering up an improvement methodology with the benefits and the use of an EHR. The whole point really of this slide is important to have a methodology, and any of them are going to work with an EHR. All of these are highly credible and have been in use for probably hundreds of years in some cases. The word there that we don't always see associated with the EHR outside of the EHR itself as an innovation, it is innovation. And innovation, just very simply defined, doing something brand new or taking something and applying it in a brand new way or in a brand new setting, typically to achieve breakthrough improvement. So innovation isn't just automating something and making something go faster or making a record electronic. That isn't necessarily innovation, but it's actually doing something brand new, so it goes beyond actual improvement, or taking something maybe from another place and applying it in a brand new setting. So we had a couple examples of some innovation here. One is from Centera, one is from Geisinger. Do you want me to go forward? Okay. So for Geisinger, what they did is they had developed, they have a EHR, and I can't remember off the top of my head which one they had, but they had an EHR in place, and what they did is they developed what they call Muse, which is a modified early warning system, and added it as a layer, as an add-on to their existing EHR package. And this Muse system provided information about the patient's well-being, which was both from an assessment standpoint and then a patient personal entry standpoint. So it's a gathering of information directly from the patient from their perspective, as well as other observations and assessments, and then certain risk factors that were pre-identified for that patient's condition. Took that information, integrated it with the EHR, and was able to give them some early warning signs and actually helped to serve as a predictive tool for them. So it helped clinicians anticipate and avoid situations. They literally have some documentation where they were able to prevent a heart attack because of this system integrating with their EHR, and they've also demonstrated that they've reduced readmissions specifically tied to the integration of this information with the EHR. And one of the things that they felt like was very important, very critical, that certainly the risk factors were important, the information from assessment, but the ability of the patient to actually input from their own perspective some of those well-being indicators really, really seems to be an important part of that predictive model. That was at Geisinger. At Centera, they created a smart screensaver or early warning system and added that to their tool. Pretty basic, but it's the patient room numbers, and they were identified, they were just color-coded. So we've got a lot of color coding in our systems as well. Green were when vitals were expected and then probably the patient was fine, their next interaction. For yellow, there was some deterioration in the patient's condition, and then red would send an automatic alert to prompt the clinician to log in immediately, see what the problem is, and determine a course of action. So they were able to set this and customize at what level something would go from yellow to red. So it wasn't just standard, it was standardized, but it was standardized with their specific input. So it was very, very custom, while it was standardized, it was very customized to their needs and to what they felt like was important, how quickly they wanted to have that alert. So they also have demonstrated through some results that the integration of that smart screensaver tool into their EHR actually reduced the number of heart attacks, and then they proposed that it actually helped them reduce mortality.
Now, in Mountain States, with Saurian, you don't see a whole lot of that because it's in that documentation section for the most part. But the nurses are already getting that. And so the system is searching for blood sugar results. And if you get more than 2 greater than, 180, yeah. 2 greater than 180, it flags the nurse, right? Because she's documenting in the system and already and whatnot. So the other, I think if there's some other ones that I'm aware of, but as we start to bring in electronic documentation on the Saurian side, hopefully that's going to become in a not overly intrusive way available to the physician. I mean, you get alarm fatigue too, so it's a balance like we were talking earlier. But you'll start to see some of that, I think. So wanted to take a little bit of time and just dialogue a little bit about opportunities for you potentially in the use of the electronic record physician order entry right now on the Saurian side, and see what ideas you might have in terms of where you could have a impact in using the system based off of what you've learned here or experiences you've had on the floor.
Are there any opportunities for
good question. Yeah, the point of entry would be that, well, at least the current group that meets is called the PAG, Physician Advisor Group, and I don't know if they're physicians. I don't typically go to that. That's kind of outside, but that would be the place, and I
would think so.
I would guess, yeah.
I mean, it's a little bit more specific and detailed than what I think you're speaking of, but, there's sepsis efforts across the system,
Yeah.
so maybe even some of those development.
Yeah, now that's a great question. And I mean, there ought to be house staff representation on that PAG group that are the ones who are, these kinds of initiatives are passing before them, and they're trying to make a decision on, okay, tweak it here, tweak it there. That's a bad idea. This is a good idea. And you're exactly right. I mean, y'all do a lot of it. Especially you do a lot of the initial care of a patient, right? So the attending might see them at 8 in the morning, but you're the one who saw them at 1. Therefore, you're the one who is or isn't using the order set, You're the one who's getting those antibiotics in within that time frame or before blood cultures or whatever the case may be. And so, you're critical to getting that patient's care started on the right foot. Sepsis, adequate hydration. I mean, the list goes on and on and on, and you're more familiar with it than I am. So great question, and I'll look into that and then get back with the department. And if there's not, I'll talk to Clay Runnels would be kind of the contact point for me, and get something done about that. It's a great idea. Any other thoughts? Right. Great question. Super users was the question. Are we going to use them? Have we used them? And there are a couple dynamics to that, a couple parts to that. You have super users who we call them green shirts. So when we did the physician order entry rollout, there were green shirts. They're not providers. I don't know. They have some, maybe a little bit of clinical training, but not a whole lot. But boy, they know the system. And they hover on the floor for like the first 2, 3, 4 weeks. And they're kind of the initial super users, so to speak, and are available when you bump into issues and that sort of thing. They do the training and whatnot. Siemens flies them in and whatnot. We have some who are here all the time, too, who will go to points of where there are issues, that sort of thing. But, one, they're gone pretty much after the first month or two. And so I know that it's an active topic of discussion that you really need both nurse super users and physician super users out there on the floor. And so my understanding is they're going to try and kind of, I guess, train up those individuals for the documentation rollout. I think we learned a few things from the physician order rollout that we really didn't do that as well as we should have. And that way, if you know that, all the nursing supervisors are super users. I mean, they've just spent extra time. They know the shortcuts, that sort of thing, and you're bumping into issues and you can't get done what you want to get done. They're there in the house at 2 in the morning that you can Vocera. You guys have Vocera, right? Yeah? No? Oh? You don't have to, oh, man. Well, it's... Exactly, that's right. Don't get me started on Vocera. Actually, it's a great tool, but it is a double-edged, just like any tool. So if it's used right, it's awesome. But if it's not used, it will drive you crazy. So, but enough on that. So I think the goal is to try and have more readily available super users. And I would argue that, I wouldn't think as an intern, but certainly, second or third year, if you, by default, you're there at 2 in the morning, and you're going to pick up on how those systems work quicker than most of us old guys. So you'd be the natural super user. So I'm going to write that down, too. Other questions? That's very helpful. The only other thing I would say is,
all that. Have you actually seen a preview of that?
Great question. No. And there was they had a small group of physicians, I think mainly from Tennessee, who took a peek at it and said, yeah, I mean, it looks workable. And now they're going to that step where,
And the reason I'm saying that is in some systems, as a student, I saw a system Meditate where I thought that physicians were more frustrated with the electronic progress notes compared to Wellmont Epic system, which flows very, very fluid.
right, right.
So both are electronic systems, but one causes frustration, the other one causes less frustration.
Right. Yeah. No, you're exactly right. And the feeling is that from those who have done some of the initial research on it is that it should be a pretty usable system. And there is some customization that can be done for it, which ought to also help. And docs get frustrated with EHRs for a couple of different reasons. One is just a bad system, But I mean, Siemens is a pretty big organization. Cerner that bought them is even bigger, and so we feel pretty confident that they're going to be able to fix the rough edges where we need to. Where was I going with that? And then the other is good training on it, right? I mean, sometimes docs are frustrated because they didn't get good training, they didn't get enough time in the training, they don't have a resource available to them 3 weeks down the road, they forgot something. How did I do that again? I don't remember. There needs to be the super user that we talked about earlier right there. Yes?
The research finds there's a significant generational gap as far as the attitude towards EHR.
Absolutely. So talking about generational gap, and I think there are a number of different reasons for that. I think the different generations, we just think differently, right? I think differently than the 70-year-old physician. It's also familiarity, right? And I mean, there's clear studies that show when you train on an EHR as opposed to a paper system, it changes the way that you think as a clinician. The way you build your differential, the way you take your history, all that is molded to some extent by that system that you're using. And that's why I think while it's kind of a hassle to have to learn multiple systems, it is good at least you see a couple different ones, because I think you'll pick up on that if you're watching for it, that one maybe fits the way that you do the HMP or do your progress note for that patient that day a little better. So familiarity, and I just think we think differently. And I think y'all, in your 20s think differently than me and Tamara in our 40s, and then some of the faculty who are in their 60s. Did that answer your question? Sort of? Yeah. 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 Other questions? We have until 5 till or 9 or run over. More information. This will be posted for you guys, I'm sure, on your website somewhere that you can get to it. And I didn't put my email address. You didn't either, did you? But you can find me if you just type in Melton SH in the system. Mountain SH, it'll pop up, I would imagine, my email. Any other questions or comments? Oh, there was one other thing I was going to say. Readmissions are one of the big areas that we're going to be tackling. They're a particular problem at Johnston Memorial, but they are a challenge across the system. And so, just kind of keep your ear to the ground for things that are happening to try and impact that. A readmission is a failure of, not all of them, but a significant portion of them are a failure of our health system. And often, you've done a great job taking care of them in the hospital, right? You tee them up, and when they land not in a nice fluffy nest for them, whether that's a facility or home with home health or just home with family. And so, that transition of care is really often where things go off the track. And, I would sometimes just a little bit of extra effort, understanding you're exhausted and it's 5 PM, you send that patient home, but to maybe reach out, whatever you may be asked to do to try and help in that transition of care, it really can have a big impact. Whether it's putting a certain amount of certain When I do dictations, I always put in there what I want that primary care doctor to do when he sees them in a week. Recheck the INR, do this, do that. I don't want them to have to figure it out because they're just trying to get up to speed on what happened, much less, okay, what am I going to do now, right? So you may be approached and asked to make sure to include those kinds of things in your discharge dictations, maybe even for the high-risk patients, for high risk for readmissions, maybe you pick up the phone and give a quick call to that primary care doc, or something along. There are lots of different ways to tackle that. Yes?
How do you do that in so many settings where there is no primary care and there is no patients that are often not going to buy their antibiotics?
Right.
How do you strategize?
Yeah, great question. So patients who don't have a primary care doc, who don't have the resources to buy their antibiotics, and that's a great point. And as a system, we're trying to create answers for that. So for example, on the antibiotics, I'm pretty sure this is at JCMC. I know it's at Johnston Memorial. We have a pharmacy right there in the hospital. And if the case management usually is driving this chain where we are, just because we don't have house staff, but you can certainly drive it too. They say, this patient, they've already told us they're not going to be able to afford their antibiotics. They're asked, and the pharmacy will deliver them and give them for free. And so they they walk out with their 10-day supply of antibiotics or whatever it is. So that's kind of one answer. For the follow-up issue, my wife works with the ETSU School of Pharmacy. So she's a clinical pharmacist. She works over at the community clinic here. Where are we? It's that way, I guess, right? About a block. And I think they have a pretty good sliding scale. So those kinds of resources that, one, are available in the community and you know about them, that's the other trick, are some of the ways that we're trying to get at that problem. And it's a problem, for sure. And in order for us to really improve population health and get our readmission rates where we need them, we're going to have good answers for you, the discharging physician, that you can have access to. And, it shouldn't, you got a lot of other things to do than coordinate discharge. I mean, it's good for you to do some of it so you understand how it works, right? But after a certain point, the educational value is, over. And so there needs to be a team around you to help with that. And particularly when you get out and you're practicing, you definitely need a team to work with you. And I know that the department's already working in that whole concept of interprofessional team care and all those kinds of things, so that the pharmacist's handling this and case manager's handling that, and that you're, to some extent, you're running the code. It's not a code, right? It's the care process, but you're freed to handle the most important things that are at your level of licensure, and also maybe a little bit of free time to do a little extra research in an area, about a patient's case and those kinds of things. Did that answer your question? Sort of? Okay. I think the time. Yes. Thank you very much. Thank you very much for your attention today. And thank you, Tamara.